By age 60, chronic low-grade inflammation becomes far more common. Immune remodeling and accumulation of senescent cells drive persistent inflammatory signaling. That signaling raises cytokine levels and impairs resolution of inflammation. The result is ongoing tissue stress, especially in joints, and gradual loss of mobility. Curcumin from turmeric interacts with key inflammatory pathways, including NF-kappa B and COX. This interaction lowers production of pro-inflammatory cytokines and oxidative stress markers. The downstream effect is a measurable change in joint inflammatory signaling that can influence stiffness and function. You will get clear mechanisms, realistic effects, and practical context for curcumin's role and limits. Hook. Challenge the belief that joint pain equals mechanical wear. Chronic low-grade inflammation often underlies joint discomfort in older adults rather than being only the result of cartilage grinding. Cellular senescence activates the senescence-associated secretory phenotype, increasing pro-inflammatory mediators such as IL-6 and TNF-alpha, which sustains synovial inflammation and sensitizes pain pathways. Mitochondrial dysfunction drives excess reactive oxygen species, which damage chondrocyte and stimulate matrix metalloproteinases, causing cartilage breakdown and reduced joint resilience. Impaired clearance of inflammatory cells and reduced autophagy in aging tissues perpetuate the inflammatory milieu and slow repair. Visceral adipose tissue contributes to the problem through endocrine signaling. Adipocytes and infiltrating macrophages release cytokines that enter circulation and raise baseline inflammatory tone, which can amplify local joint inflammation. Endothelial dysfunction reduces microvascular delivery of nutrients to subchondral bone and synovium, thereby impairing tissue maintenance and promoting pain. Synovial macrophage activation then produces enzymes that further degrade cartilage, reinforcing symptoms that may be mistaken for purely mechanical wear. Curcumin from turmeric interacts with multiple molecular pathways relevant to this inflammatory cascade. By inhibiting NF-kappa B signaling, curcumin reduces transcription of pro-inflammatory cytokines, which leads to lower synovial cytokine levels and less nociceptor sensitization in some clinical studies. Its antioxidant activity activates NRF2 and scavenges reactive oxygen species, which protects chondrocyte from oxidative damage and slows matrix-degrading enzyme activity. Curcumin also downregulates COX-2 and MMP expression, thereby decreasing inflammatory mediator production and structural enzyme activity that contribute to stiffness and reduced mobility. Bioavailability affects curcumin's practical impact. Poor absorption and rapid glucuronidation limit systemic levels when using plain turmeric powder, which reduces its measurable effects on joint tissues. Combining curcumin with piperine or using liposomal and phytosome formulations increases plasma concentrations and can enhance biological activity, which may translate into more consistent reductions in inflammatory markers and functional improvements in some randomized trials. Safety considerations include gastrointestinal upset at high doses and potential interactions with anticoagulant medications, so concurrent use should be coordinated with a clinician rather than assumed safe. Define chronic low-grade inflammation and how it increases with age. A persistent, low-intensity activation of the immune system is the hallmark of chronic low-grade inflammation. Mechanistically, a continuous, small-scale release of cytokines and acute-phase proteins keeps innate immune pathways slightly on. Causes include accumulated cellular damage and lifelong antigen exposure that shift immune balance. The effect is a sustained elevation of markers such as CRP, IL-6, TNF-alpha, and IL-1 without the clear signs of acute infection. Senescent cells drive inflammation through a secretory phenotype. Mechanism: DNA damage, telomere shortening, and metabolic stress induce senescence and trigger the senescence-associated secretory phenotype, SSP. The cause is that these cells accumulate with age because clearance by the immune system becomes less efficient. As a result, tissues experience chronic, localized release of pro-inflammatory chemokines and proteases that spill into the circulation and raise systemic inflammatory tone. Immune system aging alters regulatory balance. Mechanistically, thymic involution reduces new naive T cell output and chronic antigen exposure expands late differentiated memory T cells that produce pro-inflammatory cytokines. The cause is both reduced regenerative capacity of lymphoid organs and persistent pathogens or antigens such as latent viruses. The effect is impaired immune resolution, with a baseline of heightened innate immune activation and a reduced ability to dampen inflammation after minor insults. Metabolic and barrier changes amplify inflammatory signaling. Mechanism: expanding visceral adipose tissue secretes adipokines and cytokines, while increased gut permeability allows microbial products like lipopolysaccharide to enter circulation and engage pattern recognition receptors. Causes include age-related shifts in body composition, diet, and microbiome composition. The effect is chronic stimulation of TLRs and inflammasomes, fueling systemic low-grade inflammation that affects distant organs. Mitochondrial dysfunction and impaired clearance systems exacerbate the problem. Mechanistically, dysfunctional mitochondria generate reactive oxygen species that activate inflammasomes, and reduced autophagy allows damaged proteins and organelles to accumulate. The cause lies in declining maintenance processes with age. Consequently, innate immune sensors remain engaged longer, and pro-inflammatory signals persist rather than being resolved. Failure of resolution pathways completes the cycle. Mechanism: production of specialized pro-resolving mediators and efficient efferocytosis decline with age. The cause is multifactorial, involving metabolic shifts and cellular senescence. The effect is a chronic, low-grade inflammatory state that contributes to tissue remodeling, increased catabolic signaling in muscle, and greater susceptibility to common age-related conditions without producing overt acute inflammatory symptoms. Explain cytokines, immune signaling, and tissue degradation. Aging immune systems tend toward a low-grade pro-inflammatory state driven by increased cytokine production. Cytokines are small proteins that immune cells use to communicate. Mechanism: they bind receptors on target cells to trigger signaling cascades that change gene expression. Cause: persistent sources of stimulation, senescent cells, cell debris, and altered innate immunity drive sustained cytokine release. Effect: sustained exposure to cytokines such as interleukin-6, tumor necrosis factor alpha, and interleukin-1 beta keeps joint tissues in a catabolic, inflamed state that impairs repair. Cellular senescence contributes a secretory phenotype that amplifies immune signaling. Mechanism: senescent cells release the senescence-associated secretory phenotype, SSB, which contains cytokines, chemokines, and proteases. Cause: accumulation of senescent fibroblasts and chondrocyte with age increases SSB burden in joint tissues. Effect: local immune activation and recruitment of inflammatory cells accelerate matrix breakdown and reduce tissue resilience. Key signaling pathways translate cytokine cues into long-term tissue responses. Mechanism: pathways like NF-kappa-B, JK/STAT, and MEPK are activated when cytokine receptors engage their ligands, leading to transcription of inflammatory genes. Cause: chronic activation occurs when upstream stimuli persist or when negative regulatory mechanisms decline with age. Effect: upregulated expression of enzymes and mediators, such as cyclooxygenase 2, inducible nitric oxide synthase, and matrix-degrading proteases, drives ongoing inflammation and pain signaling in joints. Proteolytic enzymes are central to structural tissue loss in aged joints. Mechanism: matrix metalloproteinases, MMPs, and aggreconases, a DAMPs family, cleave collagen and proteoglycans in cartilage. Cause: pro-inflammatory cytokines and oxidative stress induce their expression in chondrocyte and synovial cells. Effect: breakdown of type II collagen and aggrecan weakens the extracellular matrix, reduces load-bearing capacity, and narrows joint space, which impairs mobility. Oxidative stress and impaired cellular housekeeping exacerbate degradation. Mechanism: reactive oxygen species modify proteins and lipids and interfere with autophagy and proteostasis. Cause: mitochondrial dysfunction and reduced antioxidant responses accumulate with age. Effect: Damaged chondrocytes produce more inflammatory mediators and fewer matrix components, tipping the balance toward net tissue loss. Curcumin from turmeric interacts with these inflammatory networks at multiple points. Mechanism: curcumin modulates signaling by inhibiting NF-kappa B activation and attenuating JK/STAT and MEPK signaling in experimental models. Cause: this downregulation lowers expression of cytokines like IL-6, TNF-alpha, and IL-1 and reduces inducible inflammatory enzymes. Effect: studies in cell cultures and animal models report decreased MMP expression, reduced markers of cartilage breakdown, and improved chondrocyte survival. Antioxidant and protease-related effects add to curcumin's actions. Mechanism: curcumin can activate NRF2 related antioxidant responses and directly inhibit MMP gene expression. Cause: enhanced antioxidant defenses reduce RS-mediated signaling that otherwise sustains inflammation. Effect: lower oxidative stress limits damage to extracellular matrix components and reduces the stimulus for further inflammatory signaling. Bioavailability limits practical translation and shapes observed outcomes. Mechanism: curcumin is rapidly metabolized and has low systemic absorption in its native form. Cause: this limits the concentrations that reach joint tissues after oral intake. Effect: formulations that enhance absorption, such as combining with piperine or using lipid-based carriers, are used in trials to achieve measurable biological effects, and reported benefits vary between studies. Taken together, the chain runs from cytokine signaling and pathway activation to enzyme induction and matrix loss. Mechanism leads to cause and then to effect in a clear sequence. Targeting cytokines, immune signaling, and protease activity can reduce drivers of tissue degradation, and agents like curcumin modulate several of these steps in preclinical and some clinical contexts without guaranteeing outcomes for individual patients. Connect inflammation to stiffness, morning pain, reduced mobility. Chronic, low-grade inflammation in older adults often begins at the cellular level. Mechanism: senescent cells and activated innate immune cells release pro-inflammatory mediators, such as IL-6, TNF-alpha, and other components of the senescence-associated secretory phenotype. Cause: immune senescence and reduced clearance of damaged cells allow these mediators to persist. Effect: tissues around joints become chronically irritated, setting the stage for stiffness and pain even after small amounts of use. Within the joint itself, biochemical signaling alters structure and function. Mechanism: persistent cytokines stimulate synovial cells to produce degradative enzymes, matrix metalloproteinases, and increase vascular permeability, while also promoting synovial thickening. Cause: this local inflammatory milieu accelerates cartilage breakdown and changes joint lubrication. Effect: movement becomes mechanically less smooth, producing stiffness and pain, especially after periods of rest. Patterns of symptoms reflect those underlying processes. Mechanism: during inactivity, synovial fluid distribution changes and inflammatory mediators concentrate in the joint space. Nerve endings become sensitized by prostaglandins and cytokines. Cause: overnight immobility and ongoing inflammation allow stiffening and nociceptor sensitization to accumulate. Effect: many older adults report pronounced morning stiffness and pain that eases with gradual movement and progressive difficulty performing activities that require range of motion, such as climbing stairs or rising from a chair. Curcumin from turmeric interacts with several of the molecular drivers of this inflammation. Mechanism: curcumin downregulates signaling pathways like NF-kappa B, reduces expression of COX-2 and INOS, and can lower levels of IL-1 beta, IL-6, and TNF-alpha in inflamed tissues. It also shows inhibitory effects on certain MMPs and oxidative stress. Cause: by blunting these pro-inflammatory and tissue-degrading pathways, curcumin can reduce synovial inflammation and slow biochemical processes that erode cartilage and sensitize pain pathways. Effect: in clinical settings, Supplementation or adjunctive use of curcumin has been associated with reduced joint pain and improved function in some people with osteoarthritis and with measures of decreased stiffness in trial populations, although results vary by formulation and study design. Bioavailability matters for translating biochemical action into symptom changes. Mechanism: native curcumin is poorly absorbed, rapidly metabolized, and often cleared before reaching joint tissues in measurable amounts. Cause: formulations that include piperine, lipids, phospholipid complexes, or nanoparticles enhance absorption and tissue delivery. Effect: better absorbed preparations are more likely to show consistent reductions in inflammatory markers and modest improvements in pain, morning stiffness, and mobility in trial reports. Practical context ties the biochemical effects to everyday function. Mechanism: reducing synovial inflammation and protease activity decreases friction and nociceptor activation during joint movement. Cause: when inflammation is lower, mechanical loading provokes less pain and the joint capsule and surrounding soft tissues remain more compliant. Effect: people can experience smoother movement, shorter periods of morning stiffness, and improved ability to perform tasks such as walking or standing from a seated position when curcumin is used as part of a broader management plan that includes exercise, weight control, and appropriate medical oversight. Safety and realistic expectations should guide use. Mechanism: curcumin interacts with drug-metabolizing enzymes and with medications that affect clotting, and high doses can cause gastrointestinal upset in some individuals. Cause: these pharmacologic interactions and tolerability issues influence whether a person can safely sustain a dose, likely to impact inflammation. Effect: clinicians and patients evaluate formulations, dosing, and concurrent treatments to determine if curcumin is an appropriate component of a strategy to reduce stiffness, morning pain, and mobility limitations. Introduce curcumin and its biochemical anti-inflammatory pathways. Curcumin is the primary curcuminoid extracted from turmeric. It is a polyphenolic, lipophilic compound that readily interacts with cell membranes. Through direct binding to proteins and modulation of signaling molecules, it influences multiple intracellular pathways. This multi-target activity allows curcumin to act on transcription factors, kinases, and enzyme systems simultaneously, which alters downstream inflammatory responses. Curcumin inhibits the IB kinase complex and prevents IB degradation. By stopping IB breakdown, curcumin blocks NF-kappa B translocation into the nucleus. This reduces transcription of pro-inflammatory genes such as TNF-alpha, IL-1 IL-6, and COX-2. In cultured macrophage models like RA264.7 and human monocytic cells, THP1, this mechanism lowers cytokine release and diminishes inflammatory signaling at the cellular level. Curcumin down-regulates COX-2 expression and can interfere with lipoxygenase activity. That decreases synthesis of prostaglandins and leukotrienes, key lipid mediators of inflammation. The consequence is reduced propagation of inflammatory signals in tissues such as synovium and cartilage. Curcumin also suppresses matrix metalloproteinases and adhesion molecules, which lessens extracellular matrix breakdown and inflammatory cell trafficking into joints. Curcumin modulates MPK cascades and inhibits STAT3 phosphorylation. Modulation of P38, JNK, and ERK alters transcriptional programs driven by those kinases. Activation of the NRF2 pathway is another mechanism. By upregulating antioxidant enzymes like heme oxygenase 1 and glutathione-related enzymes, curcumin lowers reactive oxygen species. Reduced RS in turn diminishes activation of the NLRP3 inflammasome and caspase-1, dependent maturation of IL-1 beta. Together, these changes shift macrophage polarization away from a pro-inflammatory M1 phenotype toward a more reparative profile. Curcumin's physicochemical properties limit its oral bioavailability. Rapid intestinal metabolism and glucuronidation lower systemic concentrations. As a result, plain curcumin yields modest plasma exposure and limited tissue delivery. Formulation strategies change that. Co-administration with piperine inhibits glucuronidation and increases systemic availability. Lipid-based carriers, micelles, and nanoparticle formulations improve solubility and cellular uptake, enhancing delivery to joint tissues in experimental models. Curcumin can alter drug metabolizing enzymes and interact with anticoagulant pathways. By modulating cytochrome P450 activity, it may change the metabolism of concomitant medications. Careful consideration of interactions is therefore important when curcumin is used alongside other drugs. The biochemical pathways described here explain how curcumin influences inflammatory signaling, and they also clarify why formulation and dosing affect its biological reach. Clarify absorption limitations and realistic expectations. Curcumin is lipophilic and poorly soluble in water. Because of that chemical property, it tends to form aggregates in the gut lumen. Low solubility causes poor passive absorption across the intestinal epithelium. The effect is low circulating levels of free curcumin after standard oral doses, which limits how much reaches joint tissues. Enzymatic metabolism in the gut wall and liver further reduces active curcumin. UDP-glucuronosyltransferases and sulfotransferases rapidly conjugate curcumin to glucuronides and sulfates during first-pass metabolism. This metabolic pathway causes most of the absorbed fraction to exist as conjugates rather than as the parent compound. The result is that the bioavailable form at target sites may be a metabolite with different potency, and tissue concentrations remain modest. Age-related physiology adds more barriers. Older adults often have altered gut motility, reduced bile acid secretion, and shifts in microbiome composition. These changes impair micelle formation and microbial deconjugation that can help liberate curcumin for absorption. Consequently, the same oral dose in a person over 60 can yield lower systemic exposure than in younger adults, and that reduces potential joint effects. Several formulation strategies aim to overcome these limits. Mechanistically, phospholipid complexes, solid lipid particles, micelles, and liposomes increase solubility and protect curcumin from rapid metabolism. For example, phytosome formulations and some proprietary nanoparticle products produce higher plasma curcuminoid concentrations compared with plain curcumin powder. The practical effect is more consistent systemic exposure, which has correlated with clearer symptom signals in some clinical trials, though not uniformly. Co-administration choices also matter. Taking curcumin with a fatty meal enhances absorption because fats promote micelle formation and intestinal uptake. Adding piperine from black pepper inhibits glucuronidation and can markedly raise circulating curcumin levels. These maneuvers cause higher exposure, but they do not guarantee clinical benefit and can increase the risk of drug interactions. Realistic expectations must be modest. Mechanistically limited absorption and rapid metabolism mean that, even with enhanced formulations, curcumin rarely reaches the high tissue concentrations used in some laboratory studies. As a result, expect possible modest reductions in pain or stiffness for some people over weeks to months, rather than rapid or complete restoration of joint function. Clinical trials in osteoarthritis report variable effects. Some participants experience meaningful symptom relief, while others do not. Safety and interaction risks change the balance for older adults. Curcumin can potentiate anticoagulants and affect drug metabolizing enzymes, mechanisms that may increase bleeding risk or alter levels of co-prescribed drugs. Reduced renal or hepatic reserve in people over 60 can also alter drug handling. The effect is that clinicians should be consulted before adding concentrated curcumin products to existing regimens. When choosing a supplement, formulation and dose matter. Mechanism-driven options, phytosomes, micelles, or co-formulations with bioenhancers generally provide better systemic exposure than raw turmeric powder. The cause is improved solubility and reduced first-pass loss. The practical effect is a higher likelihood of observable symptom benefit, but no guarantee of disease modification or universal response. Position turmeric as supportive, not curative. Aging shifts immune balance toward a low-grade, chronic inflammatory state. Mechanism: Immune cells show altered signaling with persistent activation of pathways such as NF-kappa B and increased secretion of pro-inflammatory mediators. Cause: accumulation of senescent cells and reduced clearance of cellular debris increase the load of inflammatory signals. Effect: elevated cytokines like IL-6 and TNF-alpha and higher CRP levels that sustain tissue inflammation and impair joint repair. Mitochondrial decline and impaired cellular housekeeping contribute further. Mechanism: damaged mitochondria produce excess reactive oxygen species and fail to undergo efficient mitophagy. Cause: age-related reductions in autophagy and proteostasis limit cellular cleanup. Effect: inflammasome activation, matrix metalloproteinase, MMP, upregulation, and progressive breakdown of cartilage and connective tissue that reduce joint mobility. Changes in body composition and the gut ecosystem amplify systemic inflammation. Mechanism: increased visceral adipose tissue secretes adipokines and pro-inflammatory cytokines, while gut barrier dysfunction permits microbial products such as lipopolysaccharide into circulation. Cause: age-associated fat redistribution, dietary patterns, and microbiome shifts. Effect: heightened synovial inflammation, pain sensitization, and mechanical deterioration of joints. Curcumin, the principal bioactive in turmeric, interacts with many of these molecular pathways. Mechanism: curcumin can inhibit NF-kappa B signaling, downregulate COX-2 and inducible nitric oxide synthase, reduce levels of IL-1 beta, IL-6, and TNF-alpha in experimental systems, and activate antioxidant responses via NRF2. Cause: these biochemical interactions lower pro-inflammatory signaling and oxidative stress at the cellular level. Effect: modest reductions in inflammatory markers and symptomatic improvement in some study participants, which can translate into better joint comfort and function when combined with other measures. Absorption and formulation matter for curcumin's physiological impact. Mechanism: native curcumin has poor oral bioavailability due to low solubility and rapid metabolism. Cause: the molecule is quickly conjugated and eliminated unless paired with absorption enhancers. Effect: specialized formulations such as phospholipid complexes, nanoparticles, or co-administration with piperine increase systemic exposure and are commonly used in clinical research. Turmeric and curcumin should be viewed as supportive components within a broader management plan. Mechanism: by dampening specific inflammatory pathways and offering antioxidant support, curcumin complements therapies that address mechanical load, muscle strength, and metabolic health. Cause: inflammation in older adults is multifactorial and rarely resolved by a single intervention. Effect: using curcumin alongside exercise, weight management, physical therapy, and conventional medical care may help improve joint mobility and reduce symptom burden without replacing those foundational approaches. Safety considerations and realistic expectations matter. Mechanism: curcumin interacts with drug metabolizing enzymes and can affect platelet function in some individuals. Cause: these interactions stem from curcumin's influence on hepatic enzymes and clotting-related pathways. Effect: most people tolerate turmeric culinary use well, but concentrated supplements warrant discussion with a healthcare professional, especially for those on anticoagulants or with gallbladder issues. Practical examples highlight the supportive role. Mechanism: a pinch of turmeric in food delivers small amounts of curcuminoids that act locally and systemically at low levels. Cause: supplemental, concentrated curcumin preparations achieve higher plasma concentrations and stronger biochemical effects. Effect: when chosen appropriately and used as part of a comprehensive strategy, curcumin can be a helpful adjunct that supports joint mobility without being presented as a cure. Inflammation management versus aging decline narrative. Chronic low-grade inflammation often reflects specific biological mechanisms. Immune aging shifts cell populations and function. Mechanism: immunosenescence reduces naive T-cell output and impairs clearance of pathogens and debris. Cause: accumulated senescent cells adopt a pro-inflammatory secretory profile, SSP. Effect: persistent elevation of cytokines such as IL-6, TNF-alpha, and CRP that sustain tissue-level inflammation and sensitivity in joints. Mitochondrial dysfunction and metabolic changes at another layer. Mechanism: damaged mitochondria release reactive oxygen species and mitochondrial DNA that act as danger signals. Cause: these danger-associated molecular patterns activate innate immune pathways like NLRP3 inflammasome. Effect: amplified local joint inflammation and systemic inflammatory tone that worsen pain and reduce range of motion. Gut barrier alterations contribute to. Mechanism: dysbiosis and increased intestinal permeability allow translocation of bacterial components, such as LPS. Cause: systemic exposure to LPS triggers toll-like receptor signaling. Effect: a chronic inflammatory milieu that feeds into joint degeneration. Curcumin from turmeric targets several of these inflammatory mechanisms. Mechanism: curcumin modulates signaling pathways including NF-kappa B and downregulates pro-inflammatory enzymes like COX-2. Cause: reduced transcription of IL-1, IL-6, and TNF-related genes in immune and joint cells. Effect: lowered production of inflammatory mediators that can translate to reduced joint stiffness and pain in some people. Curcumin also acts as an antioxidant. Mechanism: free radical scavenging and support for cellular antioxidant defenses. Cause: decreased oxidative damage to cartilage and synovium. Effect: potential slowing of inflammation-driven tissue stress. Bioavailability matters for real-world effect. Mechanism: curcumin is poorly absorbed in its raw form. Cause: low systemic exposure limits impact on distant tissues. Effect: formulations paired with absorption enhancers, such as piperine or lipid-based complexes, show improved systemic levels and greater biological activity in studies. Safety and interactions are relevant. Mechanism: curcumin can influence drug metabolizing enzymes and platelet function. Cause: co-administration with anticoagulants or certain medications may alter drug effects. Effect: clinician guidance is prudent before adding curcumin to a regimen. Framing matters as much as biology. Mechanism: labeling joint limitations as inevitable aging decline reduces attention to modifiable inflammatory drivers. Cause: a fatalistic narrative discourages targeted assessment and interventions like weight management, tailored exercise, dietary changes, and appropriate anti-inflammatory strategies. Effect: missed opportunities to preserve mobility and reduce symptoms through concrete measures. Conversely, recognizing inflammation as a treatable contributor shifts goals toward mitigation rather than surrender. Practical balance is essential. Mechanism: combining lifestyle interventions that lower adipose-driven inflammation and immune activation with evidence-informed adjuncts can reduce overall inflammatory burden. Cause: sustained reductions in pro-inflammatory signaling support improved muscle function and joint comfort. Effect: measurable gains in mobility and daily function for many older adults, though structural joint damage may persist. Curcumin can be one element of this multifaceted approach, not a standalone solution. Messaging should avoid extremes. Mechanism: emphasizing management and risk reduction encourages testing, individualized plans, and realistic expectations. Cause: clear communication about what interventions can and cannot do reduces confusion and inappropriate reliance on single remedies. Effect: older adults and clinicians can pursue strategies that lower inflammatory drivers, optimize joint function, and maintain autonomy without resorting to an unhelpful narrative of inevitable decline. Aging increases pro-inflammatory signaling. Immune and cellular senescence drive that change. The result is persistent, low-grade inflammation that can affect joints and mobility. Mitochondrial decline raises oxidative stress. Damaged cells and lower energy production intensify immune activation. The outcome is slower tissue repair and increased stiffness. Fat tissue releases cytokines and alters hormone signals. Changes in body composition after 60 increase that release. The consequence is added systemic inflammation and greater load on joints. Curcumin modulates pathways such as NF-kappa B and cytokine production. Its antioxidant and signaling effects underlie this modulation. The effect can be reduced inflammatory activity that may support joint comfort and movement when used alongside other approaches. Poor curcumin absorption limits tissue exposure. Low bioavailability reduces its direct activity. The practical effect is that formulation, dose, and timing matter for any benefit. If this clarified the biology and curcumin's role for you, thank you for watching. Ask questions or share your thoughts in the comments. Subscribe for future episodes that will examine dosing studies, formulation strategies, and lifestyle measures to support joint mobility. Talk with your healthcare provider before changing treatments.